I'd like to welcome Melissa and Maureen to the stage from Pegasus to talk about their initiatives. Thank you.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. How do you present after a speaker such as that? I'm feeling very intimidated, but thank you so much. Put my glasses on, that's always a good start. Look, my name's Melissa McCreanor. I'm from Pegasus Health based in Otautahi, Christchurch. Presenting with me today is Maureen Van Venrooy, who is our PCW coordinator, and also Susan Bidwell, who's our analyst at Pegasus Health. We've come along today to really talk to you about what we've been doing around collaborating to improve equity for the missing and the missing out. Namely, to talk to you about our partnership, PCW Partnership Community Worker Service. I'm initially going to do a bit of an overview. Maureen's going to talk to you about a day in the life of a partnership community worker with a case study, and Susan's going to talk around some of the evaluations of some of the work that we do. So it was quite heartening to hear the last speaker actually talk about the importance of actually evaluating what you do, and we've been trying to do that. Right at the very end, if we're really lucky, hopefully there'll be an opportunity to ask some questions. But we were hoping it was going to be really interactive, and we were going to find out what you're actually doing in your regions as well. So fingers crossed we can get there. I just wanted to start with this beautiful quote. It was initially a quote that our first ever PCW actually provided, Hoodie Pie, about actually how he saw the role of a partnership community worker. They're the eyes, the ears, the helping hands and supporting and heart of our community. So, just to quickly let you know that it's the Partnership Community Worker Service. It's a health navigation service that supports people who are not enrolled or who are enrolled but experiencing barriers that prevent them from having their needs met. Our PCWs, they work in collaboration with our Pegasus PHO general practice teams and their local communities to support those with unmet health needs to access health services. So all of our PCWs are allocated and they cover medical practices in Christchurch. And they work to really build relationships with the GP practice teams. And I'll talk a little bit more about that further on. Just to let you know, we're not a new service. We're a service that's been going for we're on our 14th year. And initially we were an initiative of Partnership Health under the Services to Improve Access funding through the Ministry of Health. And now it falls under the umbrella of Pegasus Health, where those two PHOs amalgamated in 2013. The aim, ultimately, of this service is to reduce healthcare inequalities and improve access pathways. If you were to ask me in a nutshell what the PCW service actually does, for me it's about health navigation and actually linkage, and I'll talk about that further. So you can see a little bit here about who do we work with. Our PCWs, they work with people in Canterbury, and when we're talking about Canterbury, we're talking urban Christchurch, but in terms of our geographical reach, we have PCWs that work as far as Oxford, down as far as Ashburton, so it's actually a very mobile workforce that actually covers most of Canterbury. We work with people who are vulnerable, socially isolated and alienated from support networks. You'll know these people who have unmet health needs. They're people who experience significant barriers to accessing health services, health and other support services. And we work with all ages, so mums and bubs, youth, right through to the elderly as well. Our criteria is that a Māori Pacifica low-income refugee migrant. They have to have a physical or a mental health issue, and they need to be either currently enrolled in a medical practice experiencing barriers to accessing health services, so they may be enrolled but not actually attending their GP practice, or not enrolled and actually seeking enrolment. So what is the role of a PCW? First, it's to identify and manage and reduce the barriers that a person, a whānau, may encounter when accessing healthcare. You'll know those barriers: financial, lack of information, transport, social isolation, cultural language barriers, and even people's previous experiences of health services. The aim of the PCW service is to increase independence, so individuals can be informed, have the skills and support to manage their own health and well-being moving forward. The whole focus of the service that we provide is about creating sustained change, and Maureen will go and talk a little bit about what we're actually doing in that space. I've said before, it's a mobile workforce. We're doing home visits. We're a bridge between primary care and the community. We look at whole of health, so we're not just primary care. We're supporting people in terms of secondary care, in terms of their mental health needs, their sexual health needs. We're looking at oral health, vision, dental, you name it. So what do we encounter? We encounter people with long-term health conditions, with comorbidities, multifaceted social issues. We can look at health issues, but we actually need to look at what are the social issues that are driving some of this as well for people. Most of the people that we see are non-engaged in terms of health services. They're usually experiencing significant hardship, and certainly over the time that we've been actually providing the service, we've seen increased complexity in terms of those presentations: earthquakes, mosque attacks, etc. So I just really want to focus on one of the really important parts about this service is that we actually we're partnering constantly for improved health outcomes. And our PCW service, our partner agencies, our general practice teams and community, we all work together in unity in a shared vision to improve the health and well-being of the people of Canterbury. In terms of the PCW service, we have a really unique partnership model between Pegasus Health and contracted community organisations, where we actually are working in collaboration. We have kaupapa Māori services, refugee and migrant services that we can contract with, and also social service providers working at the grassroots within their communities. We all work together. We all come together as providers, and that we're problem solving, we're collaborating, we all have different ideas about the way forward and how we want to actually address this problem, but we work towards finding solutions around our collective vision. Those are contracted community organisations we have that we contract with. We're actively involved in that relationship with them. There's 18 partnership community workers working across 9 partner organisations, so it's approximately 15.5 FTE, all based in our community, not in our PHOs. So the workers are based in the community. They're actually in the community, they're able to be seen in the community, so they're very much present. Our PCW workforce, it reflects the diversity of our target population that we serve. It's multicultural, it's multilingual. We have a range of different genders and different ages. We have 4 Māori PCWs to Pacifica. We have Bhutanese, Somali and Afghanistan PCWs as well. The workforce is really unique, and that it works in such a way where it's very, very person-centred. Maureen will go on to talk more about this, but I just wanted to highlight that they work in ways that are mana enhancing. They work with people from diverse backgrounds. They're non-judgmental, respectful relationships that are created. whilst protecting a person's values, beliefs and rights. Sometimes it's actually about starting with not what we think's right with people. It's actually about what matters to them in regards to their health. Where do they want to start? One of the places where we actually have partnered, just to quickly let you know, was with the New Zealand Red Cross. And in 2016 and through to 2018, we were provided with additional funding to reach those still impacted by the Christchurch earthquakes, to reach those still with unmet health needs. This funding enabled us to be targeted in the way in which we worked, who we were actually working with, to really try and find the missing and the missing out. So we initially had 2 FTEs. One we had hospital-based, and one we also had based in the community, and their role was primarily to find the missing. So they worked extensively with our social housing providers in Christchurch, Otautahi Community Housing, churches, hospital and family violence services as well. We were able to set up some discretionary funding with healthcare vouchers, prescription vouchers and also Metro bus vouchers, and a whole service transformation actually happened in that space. But I really wanted to highlight what is significantly important about this service is that we partner across sectors. We're not just focused on health, we're actually building partnerships, relationships with our emergency department, with paediatrics. In terms of justice, it's with our reintegration services, our guided release, and through education, low decile high schools and Māori immersion schools, just to name a few. We want to be responsive, flexible, and wherever possible establish pilots to try stuff to see if it works. And Susan will talk a little bit more about some of those pilots we've done. Currently, we have a pilot with the Christchurch City Mission. We also are in the process with Christchurch Women on supporting women on release to connect with primary healthcare as well. For us, our ultimate aim is about service integration, it's about collaboration and joining up our services. Really briefly, we see 4,600 clients per year. That 25% of those are Māori and 7% are Pacifica. 40% of our referrals come from general practice teams, but 60% come from the wider community in terms of self-referrals from a wide range across the sectors. The main barrier for people is around, as you can see, lack of information, their own physical health, transport, finance, and no support. Really quickly, 48 of those were connected back to general practice for further interventions and treatment, while 30 were linked with 30% with a wide range of other community-based health services. The benefits, as you can imagine, of such a service, and the cost benefits as well, is improved healthcare for those with the worst health outcomes. There's significant benefits for whānau, for family, for our economy generally. We have also seen, in terms of the work and the evaluations that we've been involved with, reductions in hospital DNAs, reduced ED presentations, positive client experiences of engaging with other health services at a community level, at a primary care level, but also at a secondary health as well. There's also been improved patient and general practice relationships. So those people who turn up at general practice, who maybe aren't attending, who may be enrolled but not attending. It's about actually calling them back in and actually supporting them to link back in with general practice. In the whole 14 years, we've never had a wait list. Wait lists can be a huge barrier for people in terms of accessing healthcare. We've actively facilitated contact. We go out, we do the cold calls. We go out, we're chasing up contact details to make sure we've got the right contact details for people. And we actively work to address the wider health determinants of health. I really wanted to end my part just by really talking to you really briefly about one of the evaluations that we have done, and that was through Well Connected New Zealand. It was a research project. They were very clear that there was very little known about the client experiences of health navigation services, both nationally and internationally. And they worked with the Partnership Community Worker Service in 2019 and actually did a number of interviews of clients during that time. They talked about they found the overarching theme was around the regenerative approach of the navigators towards restoring the client's sense of being, wairua, or a sense of belonging, turanga waiwai. The clients really appreciated a service approach that enabled them to feel revalued as human beings and were able to rebuild autonomy, agency, and self-determination because of that therapeutic relationship. So, Maureen?
Kia ora everyone. Sorry we're cutting into your afternoon tea, but I'll try and be brief. Prior to my role as PCW coordinator, I was a PCW. So I am very passionate about the role and how the service can make a real difference, often in a really practical but also grassroots level. So what is the PCW role? This is a quote from a current PCW who says, no 2 days are the same, no 2 clients are ever the same, and I know I'm making a difference every day. And from being a PCW, I can certainly vouch for that. So what do the partnership community workers do? The PCW role is individually based, it's short-term and task-focused. It's not an emergency or an acute intervention service. And while we can support people to attend appointments, this is limited and primarily in relation to their health. The time frame is client-driven, with the average being 1 to 3 months, and clients can self-refer. So we get referrals from GPs, from other agencies in the community, but people can also come to us directly. The PCWs can assist to gain access to the healthcare and social service, so that's linking people with agencies that are in the community. So people are being linked within their own communities. It's a navigate the health system. We can help attend appointments. This sometimes means transport. As you know, that's often a big barrier for people getting to appointments. And if that's identified as a barrier, then the PCW will certainly look at doing that. So they work to identify and address the wider needs that are impacting on their health. So that's looking at the determinants of health, such as poverty and isolation. We link to other community support service, and there's a provision for cultural support to ensure people are linked in with interpreter services. And we have Christchurch Resettlement Services that's worked a lot with the refugee community. We have, as Melissa said, we have Maori workers and Pacifica workers who work in those spaces. And always the idea is to increase the independence for people so that they are able to sustain change themselves once they have left the service. The PCW model of practice is brief intervention, person-centred, strengths-focused, solutions-focused, and it is all about sustaining change for people. So we navigate and empower, we advocate, and we link, and we walk alongside people until they're able to sustain the change themselves. The referral process for the PCW service is they receive a referral. The referrer is acknowledged within 48 hours of receiving that referral, and the client is contacted. Once engagement has happened, an assessment takes place with a plan, and out of that plan will be decided how long the service will be for them. Some people, because it's individually based, will be a longer term. Again, when we're talking about equity, some people need longer than others do. So once that plan has been completed, the client file will be closed and the referrer is let know that this has happened. However, if the client wants to come back into the service, it may be that they've been enrolled with a GP and some health issues have been addressed, but down the track something else crops up for them, they can always come back to the service and self-refer. So I'm just going to talk a little bit about a case study, and this is just one of many case study. So this is a 53-year-old Maori male with a historical sexual abuse and trauma. He has obesity and significant mental health issues, sleep apnea, and a solo father of 3 children. So the referral was received from the GP and he was linked with the Maori PCW. The client presented with multiple health issues and was unable to afford his medication. When the PCW first made contact, he had not had any medication for 3 months and no social supports and socially isolated. So the PCW worked with him and prescribed a prescription voucher that we have. We have access to health vouchers, as Melissa said, that came about from the Red Cross funding. So he was able to get his 11 medications that he had been unable to afford and therefore was impacting significantly on his health. He was also referred to the sleep clinic for his sleep apnea, and his CPAP machine had broken several months prior. That was replaced for him. The PCW also supported him at WINS, looking around his disability allowance and making sure that he had his full entitlement. The PCW also advocated at the GP with the client and attended appointments. It was also facilitated and linked into his local food bank so that he could access food himself if he needed to down the track. Due to the sexual abuse claims, this gentleman had been as a child in, I think it was 20 plus foster homes, and had absolute trauma from his childhood. The PCW assisted him with the paperwork and making a claim for a lump sum, and then he was referred on to male survivors of sexual abuse who worked longer term with him, assisting him around his claim, and still to this day are working with him. So there's a long-term plan for him. He's got the support moving forward. So this is just one of many of the complex cases that the PCWs are working with. And we have a little booklet here of success stories that we'll pass around for you, and it gives you an idea of the diversity of the clients and the work that's done. So the client voice is obtained through feedback forms, and we keep these. This is a really important part of the role, is getting the feedback from the clients. And I think that is all from me.
Kia ora, everyone. Well, I'm actually not a PCW or part of the PCW team, but I've done several evaluations with them because of my position in Pegasus Health, where I work, getting called on to do such things. Yes, so the first thing I want to talk about is our most ongoing evaluation. In 2018, Melissa and Maureen and others set up an arrangement with the emergency department at Christchurch Hospital for people who came there who were not enrolled. Part of this was driven by the post-earthquake situation, where we had a lot of temporary workers crowd into Canterbury who some of whom were from other countries and were not familiar with our health system, and immediately went to the hospital rather than thinking even about going to a GP because they weren't familiar with how our system worked. So this system that was set up was very well negotiated in the beginning, and this was one of its real strengths because the role clarity was really clear, that there was no conflict between the social workers and the PCWs and the social workers within the emergency department. So that was a real strength of it. So it was set up, initially the extra resource was provided by some Red Cross funding, which has now been taken over by Pegasus Health itself. In early 2018, I was asked to do a brief evaluation for it. And so I interviewed a number of emergency department staff, including some GPs, some ED specialists and the social workers there, and I interviewed a range of PCWs across Christchurch. And we came up with a number of clear success factors. One of these first ones was the role clarity, was everyone appreciated that. The social workers at ED told me they had absolute confidence in the partnership community workers, and the ED staff told me that they were delighted to welcome the PCWs in. The other thing that they made clear was they had a single liaison PCW who became familiar and made herself known to the staff in the ED, so everyone knew who she was. They developed this very simple little card which they gave out to people. The staff would ask them, I see you don't have a GP, would you like to be referred to a GP? Now obviously there was no compulsion to say yes. For people who said yes, this card tears in half. People filled in their name and address on the top, or their contact details, signed their permission, and then that was kept by the department. They tore off the bottom, which gave them some information about the service, and then the PCW would collect these cards and pass them out to one of the relevant PCWs in the area that the person lived in. The ED staff told me that this was a practical, simple thing that worked, and they didn't have to log onto a system, put in a password, use an app, find a machine. It was really simple, and this was another really big strength of the service. And the other thing that was very strong and has developed along the way was that because these things worked well, there was a continuing development of trust between the PCWs and the emergency department. So these were the kind of, I suppose you could say, the soft outcomes of my evaluation. There were some limitations to the evaluation. It was quite clear that we needed some better data, and sometimes it was unclear what had happened to people and so on, and what was the outcome of people who had been referred, and so that was something we agreed that we would then look at in a further iteration. The other problem was that these PCWs did sometimes struggle to find GPs who were willing to accept referrals. And this was in a context of post-earthquake Christchurch, where a lot of people had to relocate their practices and were themselves struggling. So this was I suppose I must have finished that evaluation sort of in the first half of 2018. So in the following year, between July 18 and June 19, there was a really big effort made to keep a record of everybody who had accepted to fill in this card in the emergency department. And so what we managed to establish in the middle of last year, that there had been 256 referrals that had come through from the emergency department. Remembering this is only a very small fraction of what the PCWs do in total. And of those 256, 85 of those people had actually been enrolled with GPs, and another 19 had been given other sources of support, which was 40% of all those people. Now you might say that's not great when you've got 60% who have not. And of those others, you can see that there have been some that declined support. Some of them were uncontactable. We have to remember that some of the people who come to ED do not necessarily wish to be contacted, even if they've filled their card in. And then there were other people who were ineligible for the service, perhaps because they weren't actually eligible for New Zealand healthcare or had relocated to other centres. This system is ongoing in the ED, and it is well established, and it is going strong and improving. So that was one of our, that was the big evaluation that we did that's been done over those 2 iterations. There've been some other short things that I'll just talk about briefly. The paediatric department at Christchurch Hospital actually did a quick evaluation themselves of an initiative that they had asked the PCWs to do to look at people who did not attend and follow them up and see if they could assist people to get to their appointments. That has made a decrease in the DNAs there. We also looked at a low-cost primary care practice in Christchurch who was doing a lot of work with reintegrating prisoners, collaborating with the PCW service. That was a highly valued and service, and like everybody who went through it was extremely well looked after, but ultimately became unsustainable under the current funding, and that practice has disbanded since then. And then the last thing, which was very interesting that we did, was a pilot project with the PCWs and corrections, which was called the Guided Release Collaborative Pilot. This was a very interesting exercise and learning experience. There was very goodwill on all sides, and there were indeed some successes, but a mix of logistical and perhaps you could say philosophical differences between corrections, core work and health's core work made it quite difficult. In particular, the very long distances between Christchurch City and the prisons, the length of time it took to go through security and so on, that people in prison had to be brought in to meet the PCWs. And so after a number of months, I think we had a 6-month pilot, Melissa, it was decided that it had been a very valuable experience. There had been many contacts made, but the initiative has now been decided to be redirected through the reintegration agencies that are already working in that space, because the PCWs could ultimately only offer, we're really offering health, not employment opportunities or other things that are really important as well for reintegrating prisoners. And so instead the PCWs are doing more work with Salvation Army and the various other reintegration services in Christchurch. And so that's really what I wanted to talk about. Those are the ones I've been involved in. Now Melissa's going to finish off, I think.
So that's just us talking a little bit about what we've actually been doing in that space. In terms of finding the missing and the missing out, sometimes that's actually about diving into areas where we have to collaborate, we have to actually talk, we have to actually listen, we have to find out what other sectors need and what other services actually needs. We did a lot of pilots because it was about, is this a space we should be working in? Is this a space where people want us to work in? So, and it was always about being flexible in that space, because for us it's actually about finding those with inequitable health outcomes, finding the missing. It's not just waiting for them to turn up at general practice. You can see from our stats that 60% of our referrals actually come from the wider community. That's not just the community, that is the hospital services, that is the Battered Women's Trust, that is the YWCA, that is across the sector, it's across schools, education. So our last part of our presentation was really to open this up for some questions and some answers that you might have, some Q&As. But we're really, really interested regionally to find out what others do in that space about finding the missing and the missing out. Do you collaborate for improved equitable health outcomes? And what do you see some of the challenges? You will see from, the evaluations, there were lots of learnings for us. We're not saying that we learnt from each time we did an evaluation. The reason why we did it was, what are the learnings? What are the things that we should be doing? Are we basing ourselves within the prisons, or do we base ourselves on release in terms of supporting the person? So each evaluation helped us to actually look at where was the best space for us to position ourselves. So if we open that up for questions, comments.
I'm from Bay of Plenty, and we don't currently have a PCW service, but we're thinking very hard about how we could develop one. You talked about partnering with agencies and having a coordinator. How did that work logistically in terms of who was working for whom and who got paid by whom and who's accountable to whom?
Oh, yeah, that's really worthwhile.
Okay.
That's something I found difficult to grasp when I actually started.
Pegasus is the funder. So, Pegasus is the funder. Pegasus, back in the old day, back in the early stages, actually looked at who were the services within our community who were working with the missing and the missing out, basically. Who were those social service providers who were at that grassroots level. And it was really about us approaching them, talking with them about whether they wanted to connect with us around this shared vision around addressing inequitable health outcomes. What we see, I mean, you can imagine in the early stages we had a number of high schools we contracted with, as well as social services, low decile high schools that we were involved in as well. Over time, some of those contracts have changed. We've had a real focus on kōpapa Māori services and Pacific services in that space as well, refugee, migrants, really, and connecting with a number of social services that are, I'm just thinking Christchurch, Methodist Mission in Christchurch has currently got a huge, great big program around housing the homeless. They also have social work services that are dealing directly with families and children in that space. So it's about having those conversations coming together, EOIs that go out, around who is the best, who are our partners, how do we, and who should we be partnering with. So does that answer your question?
Partly, I guess so. In order to maintain a standard and a quality across all those different providers, how did you achieve that? Or how do you achieve that? How do we achieve that? It's really interesting. One of the things is that we have myself, and we also have Maureen, who's our PCW coordinator. She coordinates the PCWs. She's actively involved in running the monthly hui's. We provide a lot of resources still to those services in terms of taxi chits, phones, all the electronic devices, a range of different supports to enable them. Because as you can imagine, we've got some providers who have quite a bit of funding, and then others that are very grassroots. Linwood Ave Community Corner Trust, it's a very, a smaller NGO in the community. The other thing that we do is we have quarterly partner agencies meetings as well. So we're meeting on an ongoing basis, and that's actually around talking about that issue around equity, updating them about things that are happening in our community. The other thing that actually, when I talked about the transformation that came out of the earthquakes, was we narrowed down our criteria. We got clear about that. We set up best practice guidelines that all our agencies have. We also have core competency training across all of those PCWs. So there's a range of supports that were put in place. Do you want to add anything, Maureen?
We, over the last 3-4 years, there's been a best practice guidelines has also been developed for the PCWs. So that's what they base their practice on, and so part of my role is orientating any new PCWs. So their employer is overseeing them, but we're providing some of the support, like ongoing training and their oversight. And as Melissa said, we have monthly hui's, and I catch up with the PCWs on a regular basis just to make sure that everything's going all right. And we're always in contact with those partner agencies as well. So there's a really strong relationship with Pegasus and the agencies and the PCWs. So the partnership is like a 3-4-way thing, really. It's the PCWs, it's Pegasus, and it's the agencies. So
we're even involved in the recruitment processes. In terms of, again, that consistency, it's about us partnering together, the agency and ourselves, in the recruitment of the PCW, knowing the wider context. The wonderful thing I see around, so the agencies actually do employ their PCW. So they, in the end, are the line managers, but there's this unique partnership relationship that is about us having to be open, honest, transparent, but being really clear about where the boundaries begin and actually end in terms of that employment, if that makes sense.
I really love that you've dipped your toes into this very messy
It is messy.
work.
It's really messy.
But could you do me a kind favor and tell me a couple things? How much money was spent? How much does it cost per person? And what did you lift? Give me all the measurements that you lift, because this is where we have to get to in terms of convincing how to take this to scale.
Oh dear, that is an incredibly tricky question, and I'm going to take your name and get back to you with all of those details. Perfect.
Yeah.
I would love to do that, because I think it comes. How do you measure the improvement in somebody's quality of life? Yes, we can do that with hook wall measures, but when you actually make sustained change, what impact that actually has on that actual individual and actually that family from a health kind of perspective, but also improving the overall quality of the life of that person is, and for those later generations, is phenomenal. If we're looking at 15.5 FTEs, you can probably do the maths in your head around some of that, but we're more than happy to get back to you with some of that data.